Okay, hello everyone. Welcome to monthly group coaching. Today's topic is headaches and migraines, and I'm very excited to share all the information that I have for you today. So let us dig in. It's 1:15. I see people joining us, so I am just going to get started, and hopefully everybody will show up, and let's do it. So I'm sharing my screen with you right now, and remember, when you're a member of group monthly coaching, these slides are available to you in the course. I think for this month there's 4 or 5 studies which I reference in these slides, so you don't have to go into them if you don't want to, but of course, I love the science, so I love sharing it, and it's there for you, but referenced in these slides. This video will be available in a few hours once it's done being processed. There are 2 links that you can share in pop science, as I call it, popular science, to share with your patients or prospective clients so that they can access easy to consume information. Okay, so without further ado, let us get going. So we're talking about headaches, and I'm just going to characterize them very quickly in terms of what we're talking about. And we're mostly going to talk about chronic generalized headaches, but when we do that, you'll see that we are also really looking at tension type because muscle tension has been found to be an aspect that contributes to generalized chronic headaches. And then there are migraine headaches. And in the studies that I share with you, it will differentiate between with and without aura, and whether that aura is visual aura or auditory aura. I'm not going to pick that apart here, but if you want more information on those different aspects, they're in the studies for you. But it's going to go a little bit beyond the depth that I'd like to get into today in our short amount of time together, understandably, right? Okay, so what are the causes of chronic headaches? And this is referenced in a case study by Donaldson that is in the course for you to read. It's very cool, easy read. It might be nice to share with your patients also, so check that out. I actually moved this because stress was the third of these 3 markers in this case study, but I moved it to the top, and you'll see why when we get done going through these slides. But stress is a #1 factor when it comes to chronic headaches. And when you think about stress as a neurofeedback practitioner, what do you think about? You think about excessive high beta. So remember that. Put that into your memory banks for now, because that's going to be a common thread throughout our discussion today. What also has been shown to contribute to headaches, and if you've heard me talk before, you've heard me say this before, is closed head injuries or mild traumatic brain injuries. In the case study, the person suffered from a mild traumatic brain injury, and in most cases, people don't understand that if they have a mild head injury in their history, that can definitely be a contributing factor to their headaches. Many times people don't even list that on the history. So if someone is coming into you, honestly, you should do it for anybody who hasn't listed a head injury, just ask them again if they have ever had a head injury. And most times they will tell you yes, even if you had that as a question on your history. Many times they won't list it because they need to be probed a little. But what a head injury looks like on a QEEG, just to remind you, I always call it low and slow. And if you remember from our concussion monthly group coaching session, and you can go back to the video in the course and watch it, closed head injuries show up as decreased power. That's low power. Many times we also see increased slow activity, which you'll see is a contributing factor here too. But the generalized decreased power, depending upon the type of mapping system that you use, it's in basically all mapping systems, it's going to look like blue, either across the board or usually in the posterior regions of the brain in the back. And 1 to 2 standard deviations would be lighter to darker blue. So you want to look for that on the brain map for someone who is struggling with chronic headaches, because that could definitely be either a cause or a contributing factor for sure. Another thing is muscle tension in the neck, in the shoulders, in the head, in the jaw. So again, they go into it in the case study, assessing it through surface EMG and looking at improvements. Actually, in this case study, it also talks about the course of treatment that the person went through, not only neurofeedback to decrease high beta and to improve power, but also stress reduction techniques and the massage therapy, muscle work to decrease the muscle tension. So the importance of muscle tension is, and there are studies that prove this, is that high beta will cause more muscle tension. So basically, the more stressed out a person's brain is, it will create more muscle tension. Then more muscle tension will create headaches and pain that will inherently continue to increase high beta. And that's the essence of a negative feedback loop. And in the last slide in this presentation, I'm going to remind you how the negative feedback loop works and the power of changing it to a positive feedback loop so that you can create permanent change, which is symptom reduction, so that your clients or patients can feel and perform better. But in the short run right now, in terms of causes of chronic headaches, we have stress, possible head injury, and muscle tension creating this negative feedback loop that's keeping someone in a mode where they get headaches. Okay, so you can check that out on the case study. Let's keep moving. Causes of migraine headaches. This is also in terms of the case study, but you'll see I've referenced Habib at the bottom. Migraine headaches are exacerbated by the things that we've just talked about, but there is an underlying brain activity pattern that is attributing to migraine headaches, and we're going to pick that apart in just a minute. It's also mentioned in the study that it's familial in nature. So what that means is, I don't think of it as genetic per se, but some people like to think of it that way. It's familial, meaning that it runs in families, meaning to me that brains don't fall far from the tree. You've probably heard me say that before. Apples do not fall far from the tree. So my brain pattern, the one I was born with, is very similar to one or both of my parents. In my case, it's just like both of my parents, whose brain patterns are very similar. And I'll tell you, they have a lot of high beta cranking. I just mapped them a few years ago. But it's nature and nurture too. So that's why stress reduction techniques work, because I've spent my life working on personal development and working on trying to create the best brain pattern that I can for myself. So I don't run with high beta, thankfully, most times, but so that it's nature and nurture, so that people will operate in a different mode, even though it's familial in nature. And it's epigenetics. So you have to remember, we can always use epigenetics to climb above our familial brain pattern. But that being said, many times people have migraines, their parents have migraines, and that even contributes more to being stuck in the negative feedback loop. Okay, so let's move on. So the point of this slide is that migraine headaches that have a different underlying brain activity and they're familial in nature. One note before we really dig into the brain pattern and the neurofeedback protocols is that another study, which is listed right here and you're going to see on the next few slides, shows that EEG is not specific enough to diagnose migraines. And when I read that, that might feel like a bummer to some people, but to me it's not, because that is not at all what we are doing as neurofeedback practitioners. So unless you're a neurologist or have credentials like that, we are using QEEG to identify the underlying brain patterns that a person's brain is performing with, and then we are using scientific techniques, neurofeedback, to optimize those underlying brain patterns towards the norm for the age and gender of the person. So we're using it to look at what patterns in terms of speed is that person's brain using, and how can we make the person's brain use speed better. That is what we're using QEEG to identify, and that's what we're using neurofeedback to do. So for us, the fact that EEG is not specific enough to diagnose migraines doesn't bother us, because on the next slide, and we'll use that as our transition, you'll see that the same study showed that there are areas of the brain that are impacted with certain patterns, and let's dig into that. So that same study showed that mostly the occipital, temporal, and frontal regions of the brain are impacted when it comes to migraine headaches. So again, we have the 10-20 system up there so that we can remind you what that is. The occipital region is O1 or O2 or possibly OZ. The temporal regions are T3 and T4, and the frontal regions can be anywhere up there in the front, but you'll see in subsequent slides, it's usually FP1 or FP2, and the lateral sides, actually F7 and F8, have also been shown to be implicated as well. So the areas most impacted by migraine headaches, that shows you the areas on a brain map that you may want to be able to look at for anomalies in the brain pattern. So when I look at a person's brain map, I'm automatically looking for a pattern in an area. That's the point of this slide. Those are the areas you want to gravitate to first, looking for the patterns that we're going to see coming up in this slide right here. Okay, so the irregular brain activity that has been identified from this study is slow wave activity, either focally or generalized. And in this case, it's primarily delta and primarily at 3 hertz. So you can see the raw EEG to the right, and you don't have to know what it looks like, but I'm trying to make a point here, because what you would see on your QEEG brain map would be reds and yellows, high excessive activity of delta. But what that looks like in the raw EEG, and you can see it here in the areas P3, P4, T4, T3 down below, is that we have fatter waves. So the fatter the wave, the slower. And you might be able to identify that on your raw EEG when it's scrolling across during a neurofeedback session. We also see spike wave formations, which you see on the right-hand side of that illustration. And you can see it again, mostly in the slower speeds, because we have these big fat waves also, but we can see the spikes within it. Spike wave formations are associated with absence seizures, and especially a pattern that's 2 seconds or longer. And if you want to know more, you can click through to when you get the slides, you can click through to the Wikipedia site that explains spike and wave formations to you, how they relate to thalamic, cortical gating, and other areas of the brain, which is very interesting if you want to know more. But so the idea is, in this study and in multiple other studies, some of which are listed in the course in your resources, you'll see that seizure activity is implicated as one of those causal or related or correlated factors to headaches. And in pediatrics and in children, we see this also. And they're absence seizures, so it's not like they're grand mal seizures that are very identifiable behaviorally. So again, this goes back to why EEG is so powerful, because we're not trying to diagnose someone with headaches or migraines. What we are trying to do is identify the areas of the brain that are not using speed well, that are using too much slow speed, in this case, on this slide, and what we can do to regulate the use of that speed. So clearly when there's too much delta, we want to inhibit delta and bring it down. So we'll keep moving forward so we can look at that. Okay, this is from another study from 2015, Hong Jing study. I love these graphics. They're actually from MEG, magnetic use of, it's like electroencephalogram, but it uses a magnet, and we get these nice, beautiful pictures of the differences in activity And let's look at the picture for a minute together. You can see over here we have migraine on the left-hand side of this image. We have a control on the right-hand side. So as you're scanning across and you can see the green arrows, you can see how they're fairly similar in the 30 to 45 hertz range, which is still fast, it's still high beta. But when we get to 55 to 90 hertz, look at this excessive activity in the lateral frontal cortex. And it's that big red blob which has a green arrow. And you can see on the left-hand side in the migraine sufferer and in the control group, there is no big blob of very fast high beta. Additionally, you can see in 90 to 200 hertz, it's on the other side, this big red blob of excessive fast wave, fast speed use. So the frequencies that are impacted are 55 to 90 hertz and 90 to 200 hertz. That includes gamma, but for our sake, we're just going to call it high beta because that's what shows up on most of your maps. And we're thinking of it as stressy speed, and it's considered hyperexcitability. Now, the interesting thing about this study and about this image is that this is resting state. So a lot of the studies that have looked at headaches and migraines try to look for differences in brain performance during a headache or at onset or in different phases of a headache. What I love about this illustration, especially for the neurofeedback practitioner, is it shows us that at resting state, there is significant difference in the way that a person's brain is performing, especially when it comes to high beta and these fast speeds. So this is definitely a marker that you're looking for on your QEEG brain map when someone comes in and complains of headaches or migraines, because we know that at resting state, just when they're living their life, that there's excessive high beta use. Another reason it's interesting is because you'll do a resting state EEG. So the person's just sitting there in the chair and you're gleaning the information from their brain activity. That's a resting state EEG, which makes it, we're comparing apples to apples here. So look for excessive high beta, and the sites that have been shown in this study to be most seriously impacted are lateral frontal cortex, F7, F8, F3, and F4 if we extend that a little bit. I know some neurofeedback systems don't have F7, F8 as a training site choice. So F3, F4 would be the next most appropriate. And you'll see, I've already mentioned it, but you'll see it mentioned again that old school neurofeedback practitioners like the Ockmers would do training at T3, T4 for headache sufferers, or would do it on one side or the other. If a person had a left side of the head headache, they'd do left side training, right side, they do right side training, and they would train down high beta. So you want to also look at T3, T4, but this study shows F7, F8. We'll extend that to F3, F4. Okay, looking at another study that is specifically on neurofeedback. It's a Walker study, and what Walker found using QEEG guided neurofeedback is that all of the patients showed excessive high beta in the range of 21 to 30 hertz. Most people showed it within 1 to 4 cortical areas. I've not listed them all here. There's a few more, not too many more, but a few more that are within the study. But the ones that had the highest percentage are P3, C3, CZ, PZ, FP1, FP2. Okay, so you're probably already thinking, she's mentioned just about every site in the brain. Yes, these studies show different sites are impacted. So of course, you need to check your QEEG brain map to look for these differences in brain performance at any site and identify the sites that are showing these patterns. Now, the cool findings of the study is that all but one of the neurofeedback patients demonstrated significant symptom reduction, including 54%, that's the majority, had complete cessation of symptoms. So awesome. So that is what we are here to do, right? We are here to identify the patterns that are causing people pain and suffering, and then we want to optimize those patterns And in the ideal world, it's complete cessation of symptoms. And there's also decreased frequency in this study, and in other studies, there's decreased intensity. The cool thing about this study was it is compared to people who took medication and they had very little symptom reduction. There was no complete cessation of symptoms. So you got to check that out, the Walker study, which is in the course under your resources. So what type of neurofeedback was done? There were 5 sessions at the affected areas. So if one area was impacted, that area was chosen. Up to 4 areas for most people, 30-minute sessions, 5 sessions at a time at each area, which is completely something that all of you can do. So we want to use our trend graphs that we're going to look at in just a minute to, after we do our QEEG brain map, we're going to identify which areas we're going to train. Then we're going to put a treatment program in place for 5 sessions at each of those areas, 5 consecutive sessions. We're going to measure progress using our trend graphs. And we're going to shoot for total cessation of symptoms. So you might be thinking, okay, specifically, what are the neurofeedback protocols that we're looking at? Depends what type of system you have, and again, it depends what the person's brain map shows. But based upon this research, we want to decrease 21 to 30 hertz. So we want to inhibit high beta. And the study showed that the protocol that was used most increased alpha, increased 10 hertz. So decreasing 21 to 30 hertz, increasing 10 hertz. If you're using a system and you choose to use a 2-sensor protocol, for left side headaches, you want to train 2 to 7 down, especially using your QEEG to inform that decision. 21 to 31 hertz down, but then if it's on the left side, you want to train 15 to 18 up. On the right side, you want to train 12 to 15 hertz up. And most of you probably know that because we are also addressing the asymmetry of the brain in appropriate ways. And if you look in the studies and you read them, you'll see that asymmetry was sometimes implicated in the underlying cause of headaches, that when asymmetry was improved, headaches then decreased, which is also very cool to look at in your trend graphs. Okay, so hopefully you're with me and you decrease 21 to 30 hertz. In most cases, you're also going to need to decrease 2 to 7 hertz if it's identified, and increase those mid-range frequencies in the alpha region, 12 to 15 hertz on the right, 15 to 18 hertz on the left. Okay, your friendly reminder to use your QEEG to inform your care. So look back at those 1020 sites, look for the patterns that I've just shared with you, and then make your informed decision making, 5 sessions at each site, gauging for progress, at least 5 sessions. And if you are in my Neurofeedback Expert program where we have people in care for at least 39 to 50 sessions, then you want to make a treatment plan. You have your mind on it at the beginning, a treatment plan that makes sense. Of course, you're going to individualize it and modify it as you go based upon what you see in the trend graphs, but knowing that you need to address the areas of concern. Okay, so let's look at 2 therapy graph changes. In this graph, you'll see the yellow lines, and you see a straight or complete line, and then you see a dashed line. The yellow lines are high beta. And this is not an extreme graph, but I have a more extreme one in the next slide. But you can see that high beta is elevated, especially on the left-hand side. So you definitely want to address left-hand side if you're going single sensor training. If you're doing dual sensor training, which this is, then you want to balance for that asymmetry like we just talked about. But what we're looking for in this trend graph is a nice downward trend of high beta across the session. So we see that downward trend up to 20 minutes. There we see high beta loosening up a little on the left-hand side, especially increasing a little bit at the end of the session. At the same time, we're training down delta, the black line, lines, and you can see it's actually higher on the right than the left because the dashed line is over the straight full line. And you can see as high beta goes up towards the end of the session, delta is increasing significantly also. So remember, most times those two brain waves or speeds go hand in hand. As the brain slows down using more delta, high beta will have to kick it into overdrive to offset that slowness. And as the brain is using excessive high beta, it can fatigue and start using more delta. So this is a nice example of training high beta down, and alpha is lower. You can see how alpha is lower and high beta is above alpha. So we would want to train alpha up in this case, and we could train 2 to 7 down also. The next graph has extremely high beta, especially on the right. High beta is significantly above delta. You can see this is a low power map to a certain extent, where once things settle down at the 15-minute mark, power is low also. The lines are down low on the graph. And you can see how high beta settles down, but it still is elevated above low beta, and it can't stay there for more than 10 minutes. We see it increasing at the end of the session. So I call that a fatigue pattern. We want to see fatigue go away across the sessions, not increase again at the 25-minute mark. So we do want to see that being able to hold itself across the session. But these are nice examples of training down 21 to 30 hertz and training down 2 to 7 when necessary, especially in the first graph, and training alpha up. In this case, alpha is a little bit higher, especially at the beginning, so you may not necessarily want to train this up using the recommended protocols that are more in the low beta range, not 10 hertz, but closer to 12 to 15 and 15 to 18. Might be a better choice in a graph like this. Okay, so hopefully you can wrap your minds around these trend graphs of how we're looking for a nice steady downward trend. Across the graphs, we want to see high beta starting lower and being able to maintain themselves lower and not be going up in a fatigue pattern towards the end of the session. Okay, but what we're going for is high beta reduction. All right, we are at our last slide, and we're doing well on time because I want to show you 1 or 2 more things after we look at the slide. I just want to show you what the studies look like and encourage you to share a case study with your patients also. But first, I want to remind you how a feedback loop works for permanent change. Just about everybody who comes into our office at Leigh Brain and Spine, as a brain health educator, I talk with them to tell them this is how neurofeedback can help you permanently. So when someone is suffering from headaches and migraines, they are stuck in a negative brain pattern. It might be caused by stress. It might have an underlying head injury. It could be that familial migraine pattern. But we know that they have this negative brain pattern once we look at it on QEEG. It is getting them negative behaviors like this slide has some of the wrong info. I need to update this right-hand column, but I will do that and I'll have it in the slides for you. So anyways, if you're following me, the negative behaviors that are gotten are headaches. So then what happens is the person can't go to school and work, and you'll see this noted as negative outcomes of the patterns in the studies. They feel terrible, they are in pain, they have decreased productivity, they feel and perform poorly. And I will get the right-hand side fixed because that's the slide from the eating disorder slide, but I will fix it and get it in the course. What we need to do in terms of headaches is establish a positive feedback loop. And the way that we do that is we decrease the negative brain pattern. In this case, thinking globally, what we're doing is we're decreasing delta 2 to 7 down, and that includes some theta too. Delta down, slow waves down. We're decreasing high beta, that excessive fast speed, and we're going to increase and boost those mid-range speeds in alpha and low beta, anywhere between 10 to about 15 hertz. When we do that, a person is going to feel better. Remember, we're shooting for total cessation of symptoms, like 54% of the people in that study achieved. Then when the person feels better, now they can go to school and work. Now they can think. Their productivity goes up. Their social life goes up. Things are better. Those better behaviors get them the better outcomes, which lock in the new, better brain pattern. And what that means is it's Head's law. So now we're locking in a brain mode that uses more alpha and low beta and uses less delta and high beta. That is what we're trying to achieve here. And, based upon that study, QEEG neurofeedback has been shown to really help people change that pattern and feel and perform better. Okay, so what I want to show you is on my website hang on, I have to share my screen again because it paused itself. Let me share. Okay, so what I wanted to show you is that on my website at drtrishleigh.com, there's a blog post that's called Get Rid of Headaches. And it looks like this: Get Rid of Headaches with Neurofeedback Therapy. It shares different science, not the science that I'm sharing with you today, in a very simple way. And it shares a case study story of a real patient in our office at Leigh Brain and Spine, who I've changed his name to Stan, but he is a 17-year-old young man, debilitating headaches. He did have a head injury, and he has familial lines of headaches. But when he came in for neurofeedback, we were able to modify his brain pattern and create that positive feedback loop for change. And he felt better, performed better. He hardly ever attended high school because his headaches made it so that he could not get there. So he had to be tutored at home to be able to complete high school. True story. Started neurofeedback with us, I think it was in his junior year. He was able to then go to school in his senior year, and he was getting better and better and better. And you know how neurofeedback works. It's not an overnight change, but it's a slow change. He was able to go to school. He got into college, and he started college courses. He had never been able to work before that. He was able to get himself a job, and he moved out with friends and began to thrive and live on his own. So at the bottom of this post, it talks about the negative feedback loop and creating the positive feedback loop in an easy to understand way. Send your patients to this blog post or recreate it in your own way on your website if you'd like. Just remember, don't copy and paste it verbatim, because if you do, it sucks the juice away from my website and it gives your website no juice. So you want to make sure you change the words if you're going to modify the content for both of our sakes. But then you'll see he had too much slow speed, he had too much fast speed. And then at the bottom is a tip for neurofeedback experts on how to get rid of headaches, and another study that shows that, you know, when high beta was decreased, people's symptoms were reduced. So that's pretty cool. Then I just wanted you to peek at what some of these studies look like. Here's the Walker study, which you will really, really like. So peek in there and check it out. This is a study on resting state activity. And I just copied and pasted one of the graphs, but you can, or illustrations, you'll see that there's more in there for you. Dive in. You can just read the abstracts to get more information. And here is the study on EEG abnormalities and migraines, and there's more in there for you. Okay, I'm checking to see if we have any questions. I do not see any questions today. As always, remember, if you have any questions for me, shoot me an email at drtrishleigh@gmail.com, or you can put it into the information, the contact form on my website. And I hope this information helps you to be able to serve your patients and to be able to help them create that positive feedback loop, help them perform and feel better and rock out their best lives. So any thoughts or questions, email me. I'd be happy to answer. And until then, let's go change brains and improve lives. Thanks.